I'm Dr. Allan Perel, and this is Conversations in Medicine. I'm Dr. Allan Perel, and this is Conversations in Medicine, a program dedicated to bringing cutting-edge medical topics to the Staten Island, New York City, and tri-state community. I want to thank our wonderful guests here, and we're going to be talking about interventional cardiology. Very cutting-edge topic. Many of you have thought about it or been involved in it when you think of catheterizations, angioplasty, stent placements, valve replacements. And it's really one of the major parts of what we're doing in medicine right now. And I have three wonderful guests. I want to introduce Dr. Richard Grodman, who's the Chief of the Department of Cardiology at Richmond University Medical Center. Welcome.
Thank you.
Dr. Srini Devori, who's the Director of the Interventional Cardiology Department, Division at Richmond University Medical Center. And Dr. Nidal Isber, the Director of the Clinical Electrophysiology Department at Richmond University Medical Center. And to tell everyone that's a mouthful, that really is a mouthful. But each one of those departments and everything that we talk about really is very, very important because we want very specialized people involved to take care of our hearts. As a neurologist, there was one time I thought all the heart was do would be pumping blood to the brain, being a brain specialist. But same as any other specialty in medicine, we think our part is so crucial. So I'm going to start with Dr. Grodman. In a sense, how does someone become an interventional cardiologist or even a cardiologist as a whole?
Okay, they start out by being an internist, so all cardiologists are internists. They know everything about the body. Then they do 3 years of training in general cardiology, followed by, if they should choose, an intervention. And there are many types of intervention. They could go into interventional electrophysiology, disorders of the heart rhythm, structural heart disease, problems with the arteries in the heart, how to fix them, problems with the valves in the heart, how to fix them. So that's how you spend an extra year or two as an interventional cardiologist.
So it's a lot of years and really a very specialized field. So Dr. Devori, you're the person, you're the interventional cardiology director. So three letters come up whenever I think about this, and it's called PCI. So maybe people have heard about these letters, and maybe tell us a little bit what the letters mean and really what kind of things do you do?
Sure. Yeah, PCI stands for percutaneous coronary intervention. Percutaneous means you're going through the skin. Coronary is the arteries that supply the heart with blood. Intervention is, the general term is angioplasty, or now it can be used interchangeable with stents. Angioplasty and stent kind of go hand in hand. So in definition, that's what that is.
So what type of cardiac disease? Maybe we'll talk to Dr. Isber a little bit. Tell me about what kind of cardiac disease do people need to do interventions for?
Of course, as Dr. Devori said, when there's blockages in the coronary artery and patient has symptoms, so you need to open the vessel or put a stent. That's one of the major intervention. Or in electrophysiology, we have a lot of diseases that need to be intervened on. In the past 25 to 29 years, we have great advances in electrophysiology and in the way how to treat this cardiac arrhythmias, including ablation. Ablation meaning cauterizing a spot in the heart that generate abnormal electrical impulse that can lead to symptoms of fast heartbeat or sudden death or other manifestation of arrhythmias, or putting a defibrillator or a pacemaker. Those are the major intervention in electrophysiology.
So before someone gets to either of you two gentlemen, or ladies, or whoever's involved in doing it, Dr. Grodman is a clinical cardiologist, and again, myself as a neurologist, I see patients. How do you decide if someone needs to go to one of these subspecialists?
There are guidelines, and generally we follow them pretty strictly. Often you have to do a diagnostic workup first, and when it suggests that somebody has blocked arteries or arrhythmias that can't be treated by simple means, medications, things like that, then you would refer that patient to a specialist who would reevaluate them and determine whether they could do the patient any good. And
So
by
tell me
good, I mean
clinically.
live longer, feel better.
So back to clinically, we're back to touching the patient. And I know we've had long conversations about physical exams. What do you, if a patient comes into you and says, I have chest pain, how would you then get to the point where Dr. DeVore would consider, all kinds of things, including, and we have all the wires here for opening up the artery. So what would they say to you? How would someone know how to get to you? Whether it's a man, woman, youngster, diabetic, what do you look for and what do you ask? And what do
Presuming
say?
that they have a general internist, that may be the first source of referral. Sometimes patients are very savvy today. When they have a symptom, they Google it and they find out what type of doctor takes care of it and make their own appointments without an internist. But the history is the most important thing. After you get an excellent history, then you would begin to examine the patient and order the appropriate tests. And then when they suggest that they have structural heart disease and they need the services of these gentlemen, the referrals can be easily made.
So not everyone who has chest discomfort or chest pain needs to jump all the way ahead.
Most people don't.
And the workup before we get there, tell us a little bit about stress tests and what they are. So many of our patients go for routine stress tests. Is there such a thing as a routine stress test?
There really isn't. A routine stress test is not recommended because there's a high incidence of what are called false positives. The test is really normal, but it comes out normal, and the patient's now worried that they have a disease they don't really have. Regular stress tests are better than the flip of a coin, but not a lot better. And they're only indicated in somebody that is at risk for having coronary artery disease, not the general population.
So both as an interventional cardiologist and someone who has a practice, a wonderful practice who I know very well, Dr. DeVore, tell us, if someone comes in with chest pain, what steps till we get to doing this? And the second part is, that's in your office. The second thing I'm going to ask you is, what happens in the hospital when someone comes in with some emergent situation?
So the presentation can either be as elective. Somebody says, look, I have some risk factors, high blood pressure, diabetes, I'm a smoker, or, I had family history of heart disease, one of my parents had heart problems, they had a heart attack, bypass, so I'm concerned. So I had this pain, pressure I had it walking uphill the other day, so I want you to do a stress test on me. Sometimes they come and say, and that is a typical scenario. And then I have, in my group, 2 other physicians, and they're more clinical, so one of them does the stress test. Walk on a treadmill if the EKG baseline is completely normal, or if the EKG has subtle changes at baseline, then we can do one of imaging tests, exercise with a nuclear test or exercise with echo. And if they have symptoms and or changes on the EKG during the test, or the squeezing function is abnormal, or the blood flow to the different segments of the heart, the main pumping chamber, are abnormal, then they will come to me.
And once that decision, so we're going to go all the way ahead. So someone has chest pain or shortness of breath, Dr. Grodman, different cardiologists who are not doing the intervention themselves, evaluates the patient, and everything looks like there might be a blockage in one of the arteries.
Yes.
Second scenario that I want to talk about is really the thing that scares almost everyone, all of our wonderful viewers and people out there. Someone who, after Thanksgiving dinner, has chest pain, tells his family, his or her family, I think I just ate too much. Should they go to the hospital? Should they not go to the hospital? If they get to the hospital, what do we do, and how do we decipher whether this is a true emergency or not?
Yeah. Certainly the general recommendation is, if you feel something that you never felt before, even if it just happened to be right after eating, do not take a chance. This could be the heart, this could be just agita, this could be muscle, but don't take a chance. If you suspect, if you have the symptoms, go to the emergency room. The worst thing that can happen is you do a workup, everything is okay, so you go home. No embarrassment. However, the other scenario, they come in, they think it's the food, but actually there are changes on the EKG. We do some blood tests to see if there's any damage to the heart muscle, and we can diagnose heart attacks or impending heart attacks, what we call unstable angina. So they didn't have a heart attack, but the symptoms are very, very typical, and then we go ahead and do the invasive testing to see, and in those cases we skip the stress test. Why? Because waiting for the stress test may increase the risk. So we go ahead to the catheterization.
So this is a hospital emergency. Someone
Yeah,
comes
that's an
in there, this
emergency.
becomes an emergency.
That's an emergency.
And I think there's some terms we use, something called STEMI, non-STEMI. Maybe people might have heard that if they're in the hospital. What do those terms mean?
Well, everybody knows the term heart attack, but fewer people know the term myocardial infarction, which is a fancy word for heart attack.
Myocardium is the heart and infarction is dead heart.
Right, or STEMI means an ST segment elevation myocardial infarction. That's an EKG change that signifies a heart attack. So those are the things that are diagnosed immediately with the heart attack team in the emergency department, and the patient is brought instantaneously to the cath lab, and the team is assembled and they're taken care of.
And this is very quickly.
And that's
Very
a true emergency.
So tell us what the catheter is and what catheterization is. I mean, catheter just means a tube.
A tube.
So someone who has this impending heart attack or unstable angina, as
So
you mentioned,
let's just-
what's our next step? and
Yeah,
what-
let's say somebody hits your emergency room and we suspect this. First thing we do is treat them. Start treating them as though it's a heart attack because of a high index of suspicion, or if there are changes on the EKG that suggest it's a true emergency. Number one, we give them aspirin. Number two, we give them another medicine similar to aspirin. Many people may know Plavix. There are other medications as well. And we control their blood pressure, and we take them to the catheterization lab or suite, where we can either do it from the wrist. We do 75% of them these days from the wrist.
That's the radial artery. That's the
Radial
that you
artery,
talked
artery
about
from here.
Right.
Or from the groin, it's called the femoral artery. We thread this tube. After we obtain access to the artery, this tube
And
goes
that's
all the
actually
way.
the tube.
This
That's
is the tube.
actually it.
This is 2 millimeters in thickness. It goes all the way up to the heart, and then we inject dye or contrast and look at the arteries on a X-ray machine. We have 3 major arteries, one on the right side. This one goes down, supplies the bottom of the heart. Main pumping chamber is here, the left ventricle. On the left side, it begins as one main artery and divides into this one in the front, what we call LAD, or left anterior descending. And then the third major one goes in the back, supplies the back of the main pumping chamber.
And any of those arteries can cause, if they're blocked, can cause a heart attack.
Any of them can cause a heart attack.
So keep on. I'm sorry, I don't mean to
It's
interrupt
okay,
you.
no, it's
So
very good. So it's important for us to say, once we define where the blockage is, then we give them blood thinners through the vein, because once we see the either blockage or 100% blockage, then we put this thing, it's called a guide wire. It goes through this same catheter. It's a very fine wire, if you can see, because this has to go through these fine, thin arteries. And the arteries are somewhere 3 to 4 millimeters in diameter. So you put the wire through the blockage, and then we put a balloon, which I brought. I don't know if you can show it. And so this balloon, we thread it over the wire. And once it gets to where the blockage is, we inflate it with this machine. It's called a little gizmo called an inflator. And then we inflate this balloon and open the artery. And once we open it, if you leave it without putting a stent, which we have learned in the last 25 years, 30 years, is the artery can potentially reocclude or reclose. So we put something called a stent, which is mounted on a balloon, similar balloon. It is laser crimped. This is actually, I brought a larger one. This is for the peripheral arteries, but to be able to see better for the audience. So we put this across the blockage, inflate the balloon, expand the stent, and then deflate the balloon, take the balloon out, and the stent keeps it open so it does not collapse again. And that's how we stop the heart attack.
is it usually successful?
It is successful in a 98+% of the times. And from the time they hit the door to the time we open it, there's something called door to balloon time. And our aim is to get it as low as we can, but certainly less than 90 minutes.
So the shorter the time, the more likely someone will do well.
Shorter the time, more muscle we save, stop
And-
the damage.
And I'll use an example that I do is running the stroke center at our hospital also, is that time is brain.
Time is brain,
The
so time
longer
is
it takes
muscle.
to reestablish blood supply, whether it's through what we call TPA, a clot buster, or some of these catheters that are now being used
Yes.
for endovascular treatment, that saves brain. So saving the heart muscle, and does saving the heart muscle have a much better prognosis than losing heart muscle?
Yes, so the arteries that we have, the main purpose is to supply oxygen, so the left ventricular main pumping chamber can work as a pump. It is a muscle, it's a pump. So the more heart damage we have, the more symptomatic they will become. They can go into congestive heart failure the longer we wait. So if you take care of it early, you minimize the damage.
I'd like to mention to your audience, while this can be done very quickly and generally is, the real problem is patients don't come in right away. And they may spend 3 hours at home before they come in, damaging their heart muscle. So everyone with chest pain that is worrisome should come in right away.
I have Dr. Isber here, who's a marvelous electrophysiologist, which deals with the electrical conduction of the heart. So palpitations are such a common symptom that people describe. Does everyone who have palpitations need your services to do different things, or how do you evaluate someone with palpitations?
It's a wide, large subject, palpitation, but any feeling of the heart called palpitation, usually at rest, we don't feel our heart. And if somebody feel their heart either fast or skip beat, this is by definition is palpitation. Not everybody need, of course, treatment. Some people have palpitation, very mild, very tolerable, so they don't even seek medical attention in years. But when it becomes bothersome, they do seek medical attention. The significance of palpitation varies widely. It could be ranging from non-significant to sudden cardiac death, a marker of sudden cardiac death. So there are specific, of course, diagnostic testing that we use in order to risk stratify these patients and see what is the significance of this arrhythmia. Start with extra beat like PVCs or extra beat in the atrium or in the ventricle, which has no significance. However, even those non-significant arrhythmia could be very significant on the long term if the burden or the amount per hour or per day is large. It can even progress to heart failure. Those even non-significant arrhythmia could progress to heart failure.
So it's very important that if someone has palpitations, that they see their cardiologist, their internist, and their cardiologist in order to define whether someone such as yourself would help do it.
Some patient will have arrhythmia for so many years. They have palpitation, and they go to the emergency room, arrhythmia terminate in the way, they arrive to the emergency room and there's nothing on EKG and they are labeled as anxiety, and they are actually, they carry this diagnosis for so many years before arrhythmia is discovered, or if they are lucky enough that their arrhythmia is sustained enough to be detected in the emergency room, to be detected. So there's so many people that don't really, they are not diagnosed with arrhythmia for so many reasons.
I'm going to go ahead to something that's very complicated and something that people are always worried about. Something like a pacemaker. Mm-hmm. People talk about pacemakers all the time. What's a pacemaker?
Pacemaker is a device that is implanted that's used in people who have slow heartbeat. It's a small device that has a battery sufficient for about 10 years nowadays. We implanted in the left pectoral area by doing small incision, and we put leads in the heart through a vein that goes to the heart. Usually pacemaker has 2 leads. We put them in the right ventricle and right atrial appendage. Mm-hmm. And
show us those things. We have the heart right here.
Okay, this is the right ventricle. So the vein, the lead comes through an incision here. We go to the vein, we go to the subclavian vein or to cephalic vein, and through this vein we go to the heart all the way, and we put it in the right ventricular apex here. And this is a first lead. The second lead, there's right atrial appendage. Through the same thing, we go here and we go to the right atrial appendage, which is here. So these 2 leads will always sense the heart and pace the heart when necessary on demand. The indication for pacemaker is usually slow heartbeat. That is usually symptomatic. Like the generator of electricity in the heart, we call it sinus node, that's not generating enough heartbeat per minute, like slow, a heartbeat of 40 or 45, and they are somewhat symptomatic, fatigue, tired, or they have syncope or dizziness. This is an indication for a pacemaker. There's other more sophisticated pacemaker that we use it when there's conduction disease in the heart.
Let's talk a little bit about AICDs. Tell us what do those initials stand for, and what do people who have weak hearts, people with heart failure, people with various arrhythmias, maybe just start a little bit about what are those kind of implantable devices?
Generally, an AICD, an automated implantable cardiac defibrillator, is a shocking device which will terminate a lethal rhythm disorder. So does everybody need one of those? No. But people who are at risk to die suddenly because of a particular heart condition can be saved by this device. So if it detects an abnormal heart rhythm, first it tries to pace you out of it, and if that fails, it shocks you, and generally is very, very successful.
Okay. Tell us a little bit about valves. And Dr. DeVore, I know that you do a lot of the work here with opening up arteries, but there's been so much research and so much, not even research, but things that are happening now
Yes.
about being able to put a heart valve in without opening up your chest.
Yes.
I think that's wild for a neurologist, for a physician of any kind, for a family person, to think that someone could put in one of those valves without actually having to do surgery or open surgery is a tremendous advance that we have.
Absolutely.
So tell me a little bit about it for our patients who might have valvular heart disease, and maybe just describe what valvular heart disease is.
Sure, absolutely. So we have 4 major valves, 2 on the right side, 2 on the left. So this is the atrium. The blood, blue blood from here goes through this valve, it's called tricuspid valve, into the right ventricle, which pumps blue blood through the pulmonary artery into the lungs where it's oxygenated, comes back through here into the left atrium. Sorry, I forgot to mention. The right ventricle goes through the pulmonic vein, so that's 2 valve. So 2 valves on the right side. The oxygenated blood comes to the left atrium, through there goes through the mitral valve into the main pumping chamber, left ventricle, and the left ventricle pumps blood through aortic valve into this big red structure, that is the aorta. So we have 4 valves. So when we're talking about valve replacement, without operation, without surgery, without cutting, we're talking primarily about this aortic valve. As we get older, not everybody, but some people, where the valve narrows because of calcification and scarring or fibrosis. So in patients who cannot undergo the open chest valve replacement because of multiple conditions that they have, bad lung disease, diabetes, the kidneys are not good, they cannot tolerate major surgery because they're so frail, they're 90 years old. So these are the people who had no option but to say, I'm sorry, Mr. Something, you, in the next 5 years, you will not be with us anymore because the valve gets narrower and narrower and until
And that way blood
Just
flow
stop.
won't be able to go through, or it backs
Correct.
up and causes pressure and
correct,
breathing
goes
problems.
to heart failure and cardiac arrest. So in those high-risk patients, the cardiac community started putting these kind of catheters, but much bigger ones, through the groin, go through the valve, cross the valve in the reverse fashion, go through and get into the pumping chamber, ventricle, open it with a balloon, and mount a valve, the cow valve, into that artery, into that valve, open it, and the person suddenly gets symptomatic relief, and they don't have the congestive heart failure or the shortness of breath or chest pain, and that has been remarkable in the last 15 years.
That's absolutely amazing. So tell us a little bit about the team. You know, clearly you guys are wonderful, and I wish I could say I could ever do anything alone. I can't in my office or my practice or as part of a hospital being on the stroke team. I can't do it all myself.
Yes.
I have 3 wonderful cardiologists here. Tell me about the team of people that you work with, especially in the interventional field.
Well, in intervention, you need to have, excellent nurses to work with us. We need to have support staff such as PAs. In some hospitals, they have nurse practitioners. And we have cardiologists in training, what we call cardiology fellows. And then we have colleagues that work with each other. And at times, when the decision is not so clear, we have conferences with Dr. Grodman, other cardiologists. We have CAT conference. We make a decision in elective cases what needs to be done, and then we all work together in the lab. It is the cardiologist, a cardiology fellow, the nurses, and maybe a PA. It takes the whole team to have a successful program and do the right thing for the patients.
We have only a couple of minutes left, and I'm going to drop a bomb here. The idea of heart transplants sounds like such a big thing, of course. Tell me a little bit about how would someone know that they need to have a heart transplant? Is it something subtle? Is it something that is really thought out over time? Tell us a little bit about
Generally, no. It's the end stage of heart failure. Generally, the patient has had heart failure for a long time. Rarely, it's quicker with a virus or something like that. Not everybody is suitable for a heart transplant. Even if they are, there are very few hearts available. There is a lot of transplantation done in the country, but unfortunately, not everybody can have it.
Okay, so
Substitutes are what are called left ventricular assist devices or artificial hearts, and more people are having those today that have been very helpful.
tell me a little bit about some of those devices.
Yes, so the left ventricular assist device, when the left ventricle or the main pumping chamber is very weak, either as Richard mentioned, because of a viral illness in a younger person, or people who have had a heart attack and they presented to us late. So in spite of opening the artery, the heart muscle does not recover, and they cannot breathe, they cannot walk 100 feet, they cannot sleep flat, they gotta sit up because of shortness of breath. In those people, they put what's called left ventricular assist device if they're not candidates for transplant. And this is a mechanical device that pumps blood from the ventricle into the aorta, relieving any effort on the ventricle.
If I have to say, 30% of heart failure patients, they have conduction disease. The conduction system that conduct electricity from the upper chamber to the lower chamber.
That puts the heart in sync, in other words.
Yeah, one of the conduction disease, left bundle branch block, is blocked, so the heart dysynchronous. And 30% of heart failure who are end stage, they can significantly benefit of implantation of a resynchronization device with a defibrillator and pacemaker embedded in one. And we have seen a reversal of heart failure symptoms from stage 4 down to stage 2 or even 1. And that's before we undergo, of course, the LVAD device that need open heart surgery and so on.
I want to thank everyone for being here tonight. And what I'm hearing from you, and what's so important to really conclude with, is that people like yourselves help maximize how patients are. So get to your doctor, see your physician, see your cardiologist. There are ways to make situations that you might not think will work well much better, whether it's through helping out arrhythmias, helping out through increasing blood supply, and doing a number of things like that. And you bring a wonderful service out to Staten Island and throughout the whole tri-state community. I want to thank you all for being here, and thank you all.
Thank you.